All right, now we move on to that part of the burn issues that deal with the fluid resuscitation. Vignette number 13, an adult male who weighs, and you'll be told how much, X number of kilograms, sustains second and third degree burns, and there will be a little drawing in that question showing you the areas that are burned. And then after you're told what was burned, second degree, third degree, etc., you'll be asked about fluid resuscitation. Now we know that underneath burns, both second and third degree, there is a lot of fluid that is trapped, and we know that in the initial treatment of a burn victim, they need vigorous, extensive fluid resuscitation because that fluid is not in the circulating space anymore, and for about 2 days they're going to depend on that additional fluid to maintain good perfusion until the healing process eventually brings back the fluid that was trapped under the burn area. Because we're talking about large amounts of fluid that will have to be given over a short period of time, there are a number of formulas out there devised to allow an estimation of how much fluid may be needed. Let me emphasize before I go into the formulas that this is an estimation only. Once we initiate the fluid resuscitation of a burn patient, we then judge the adequacy of our efforts by the response of the patient. And we judge primarily by taking a good close look at hourly urinary output, central venous pressure, and we attempt to maintain an acceptable hourly urinary output without pushing the patient into overt excessive transfusion and elevated venous pressure. And therefore, whatever we came up with as a result of a calculation in the formula, again, was only an estimation that later needs to be fine-tuned. But it is possible that you might have questions on the exam that call on you to make that estimation. I regret to tell you that there isn't one formula. There are multiple formulas in use. So the answer could be any and a number of different ones. I'm going to review with you the one that I think is most commonly used presently as the modified Parkland formula. Now all of these formulas use as the input into the calculation the body weight of a patient in kilograms, the extent of a burn as a percentage of body surface, and then a factor. And this factor is the one that is different from one formula to another. You multiply all those things, you come up with a number of cc's of fluid that are going to be needed. Okay, we have to start then, if we have this vignette, calculating the percentage of body burn. The kilograms of body weight will be given to you in the question. To calculate the percentage of body burn, we use the famous rule of nines. I'm going to go to the board and make a drawing to give you the rule of nines, and I'm going to do it for both the adult and the child so that we cover both of them. Let me start with the adult. So we're going to have typically two pictures in the examination question. One will be the front of the patient, and the other picture will be the back of the patient. So let's say that this picture here is the front of the patient, and then there'll be next to it another picture which will be the back of the patient. That's his hair there. And then, as I pointed out, the picture will show in the exam the shaded areas that tell you what was burned on the patient. Okay, here goes the rule of nines for the adult. The head represents 9% of body surface. Each upper extremity represents 9% of body surface. The trunk has a total of 4 nines, 2 in the front and 2 in the back. And each lower extremity has 2 nines, 1 in the front and 1 in the back. So there you have. So if we count, there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and 11. 11 segments of 9% each adds up to 99, and since it's only for an estimation purpose anyway, it doesn't matter where the remaining 1% went, okay? And the child, though, as you know, children have big heads, bigger than they are in relation to what it would be in the adult, and smaller legs. So in a child, it would be like this. If you have a little drawing of the child would have a big head like that, and then the little body here with relatively small little legs here. I realize I'm exaggerating here, but I'm trying to make the point. So in the child, the head accounts for 2 segments of 9. The trunk and the extremities, upper extremities, are the same as in the adult, but the 2 lower extremities add up to a total of 3 9s rather than adding up to 4 as they do in the adult. So the extra 9 that was given to the head in the child comes from the legs, which in the adult would have had 4. All right? So we have in that to begin with. We can estimate the percentage of the body surface by using the rule of 9s either in the adult or in the child. So once we have determined the percentage of body surface, here is the modified Parkland formula. Kilograms of body weight times percentage of body surface burned up to 50. Let me explain that. If a patient is burned more than 50% of his body surface, he already is losing fluid at the maximum possible rate. So there is no more fluid to be lost in the 60 or 70 or 80% burn than there is in the 50% burn. So what we plug into the formula is a number up to 50, and if a patient was burned 60 or 70, we still plug only 50. Now that percentage of the body burn is plugged in as a whole number, so I'm not asking you to put 0.2 or 0.3, but to put 20 or 30 or 40 or 50. So we started again with the kilograms of body weight times percentage of body burn up to 50, times that other factor, which in the modified Parkland formula happens to be 4 cc's. In other formulas, it is 2 cc's. So the formulas we use in the adult plug the kilograms of body weight, the percentage of body burn up to 50, and the number that could be 2 or up to 4, depending on the formula being used. Modified Parkland would be 4. When we multiply that, that gives us the number of cc's of a balanced electrolyte solution like Ringer's lactate that the patient will need in the first 24 hours. And half of that should be given in the first 8 hours, the other half in the next 16 hours. In addition to that, a patient with extensive burns typically cannot eat and drink for a day or 2. They need maintenance fluid just because they are not eating and drinking, and typically an additional 2 liters of fluid are allotted for that purpose. These are often D5W. The Ringer's lactate, I might point out, is best used without sugar, so we don't induce an osmotic diuresis that then would invalidate the reading of the outer urinary output. Let me say it one more time. So if we have a question on the exam that gives us the 2 little pictures, front and back, of a patient that sustained burns, and we're asked how much fluid do we estimate the patient is going to need, we have to calculate the percentage by the rule of 9s, and then multiply that number by the number of kilograms of body weight, and in the case of the modified Parkland formula, by 4. Those are the cc's required on day 1, plus a couple of liters because the patient cannot eat and drink. On the second day, typically the needs are only about a half of what they are on the first day, and on the third day, we should no longer need intravenous fluids, but on the contrary, on the third day, all the fluid that had been trapped under the burn begins to come back to the patient. And on the third day, we in fact should see an extensive, vigorous diuresis on the part of the patient, even though he may not even be getting fluids anymore at the time. And this is normal, to have that diuresis on day 3. All right? Well, let me go through a few additional questions here where we'll touch upon some of these issues. I pointed out, though, and this leads me now to question 14. I pointed out that all of these formulas only provide an estimate, not a precise number to be obeyed no matter what. Because they're only an estimate, there is actually what I think is a good, healthy trend on some burn circles to, rather than going through this whole calculation, simply pick a number that provides a generous infusion of fluid to begin with, and then simply go by monitoring urinary output. So here is a question that phrases it in that different way. Vignette number 14. An adult who weighs X number of kilograms, you'll be given the time, has third-degree burns over, and you'll be given the drawings, and it will turn out to be more than 20% of body surface. And then rather than asking you, estimate how much fluid he will need for this whole 24-hour period, the question might say, fluid administration should be started at what rate? If we are asked a question in that fashion in the adult that's got at least 20% burn, a good answer would be, let's begin at about 1,000 an hour. We know it isn't going to continue at 1,000 an hour. We know that eventually it'll be less than that. But that is enough to get us going. And then as we monitor urinary output, we'll decide whether he needs less or he needs more. Okay. Vignette number 15, an adult male who weighs X number of kilograms, has third-degree burns over, you will get the drawings. How much is the estimated amount of fluid that will be needed? Then we'll have to use the formula. So let me point out again. If we're asked at what rate should we begin, we don't need to go through the formula. In the adult, we begin at 1,000 an hour. If we're asked what do we think is going to be the total need, we go through the formula that we just went by. But let me move on to the next few vignettes, because as I've been pointing out time and time again, these formulas don't have a very accurate predictive value. Let's read vignette 16. After suitable calculations have been made, a 70-kilogram adult with extensive third-degree burns is receiving Ringer's lactate at the calculated rate. In the first 3 hours, his urinary output is 15 cc's, 22 cc's, and 18 cc's. All right. Is that a good urinary output? No, it is not. Let me remind you, a normal hourly urinary output in any human being is approximately 1 cc per kilogram of body weight per hour. So a 70-kilogram man normally should produce about 70 cc's of urine every hour. And in fact, because there is a range to the normal production of urine, we would accept anywhere from half that to twice that as being within the normal envelope. So repeat again, a 70-kilogram man ought to make, under normal circumstances, at least 35 cc's of urine every hour, more likely 70 cc's of urine every hour, and up to 140 cc's of urine every hour would be considered normal. If we're now resuscitating this patient from burns and aiming at the normal urinary output, we're aiming at least the 1 cc per kilogram body weight per hour. In fact, in some circumstances, if we want to protect the kidneys from damage, we may even want to aim for 2 rather than 1. So in that context, let's look at these numbers again. We are doing the resuscitation as the formula suggested we should. But in the first 3 hours, his urinary output is 15 cc's, 22 cc's, and 18 cc's. obviously this man needs more fluid. The answer in this question on the exam would be we need to increase his rate of fluid administration, because regardless of what the formula estimated, reality says he's only making a very small amount of urine. He needs more fluid. Well, let's look at the other side of the equation. Vignette number 17. After suitable calculations have been made, a 70-kilogram adult with extensive third-degree burns is receiving Ringer's lactate at the calculated rate. In the first 3 hours, his urinary output is 325 cc's, 240 cc's, and 270 cc's. This is a 70-kilogram man. We would expect him to make 70 cc's an hour. We would accept that still within normal boundaries if he made 140. We may, in fact, have wanted him to make 2 cc's an hour, 140. But if he's putting 325 and 240 and 270, he's way above that. Regardless of what the formula estimation said, the fluids that are being given to this patient are more than he needs. And therefore the answer on this question on the exam would be we need to reduce his rate of fluid administration. He needs less than what he's been given. But I hope you'll be able to identify that the situation is different on vignette number 18. During the first 48 hours after a major burn, a 70-kilogram patient received vigorous fluid resuscitation and maintained a urinary output between 45 and 110 cc's an hour. And we know that would be appropriate for a 70-kilogram person. On the third post-burn day, after IV fluids have been discontinued, his urinary output reaches 270 to 350 cc's an hour. And now you're asking yourself, was he mishandled? Was he given too much fluid? Why do we have this gigantic output? Or has he gone into high output renal failure? No, none of those things. Remember we said at the beginning. In the first 2 days, you need a lot of fluid to keep perfusion. But by the third day, the fluid that was trapped under the burn begins to come back. Now you got your own fluid coming back, plus all the fluid that was given to keep you alive, and you have the vigorous diuresis. This is normal. Okay? So the answer in this vignette is, this is to be expected. We don't need to do anything about this. All right, now the next couple of vignettes have to do with babies. An 8-month-old baby who weighs X number of kilograms is burned over, and again, the drawings will be there. Second degree will look the same as in the adult. Third degree in babies is actually deep bright red rather than the leathery, charred, grayish color that it has in the adult. I pointed out to you the differences in the rule of nines. 2 9s for the head, a total of 3 9s for both legs as opposed to 4 in the adult. Otherwise, the formulas in the babies are similar but tend to give more fluid than they do in the adult. So whereas in the adult, the third factor in the formulas was either 2 to 4 cc's, in babies is 4 to 6 cc's. All right. Now, you might have questions on the exam dealing with burns, but not centered on fluid resuscitation, but centered on everything else that is needed by the burn patient. Actually, rather than writing 5 or 10 different questions, I just wrote here, a patient with second and third degree burns over 65% of the body surface is undergoing proper fluid resuscitation. And the questions ask about management for the burn areas and other supportive care, and it may be directed to a number of things. So here is a summary of the other features of burn care. You have to realize this is a summary. We are reviewing in a few hours a body of knowledge that would typically take years to acquire and to become proficient with. First of all, burns, like any other injury that breaks the skin, calls for the appropriate management regarding tetanus prophylaxis. I'm not saying every burn patient has to be given tetanus toxoid or whatever. If the patient had tetanus toxoid a month ago, he doesn't need it. Again, what I'm saying is whatever is appropriate for tetanus prophylaxis for that individual, that thought has to be triggered by the fact that a burn occurred. Then there is suitable cleaning of the areas. This usually begins in an operating room where we clean out all the burn areas and do the gross debridement that is appropriate. But then the topical care of the burn area is all based on the use of topical agents. You see, there is no parenteral antibiotic that could kill all the potential bugs that could enter a patient through the burn area. And so topical agents are the key. The standard topical agent, the workhorse, the one we use in most circumstances, is silver sulfadiazine. It's a soothing white paste, makes the patients feel good when you put it on, doesn't hurt, and it protects very well against bacterial invasion. There are a couple of other things, though, that we have available. If we desire deep penetration, because there is a thick eschar, for instance, or because cartilage is involved, the mafenide acetate is a better agent. Mafenide acetate is not the workhorse we use everywhere because it hurts and it can produce acidosis. But if we need it specifically for deep penetration, it is appropriate. Burns near the eyes are covered with triple antibiotic ointment. We prefer there one of those ointments that has 3 non-absorbable topical antibiotics because our standard agent, silver sulfadiazine, is very irritating to the eyes if it gets into the eyes. Next item, pain medication in the first day or two has to be given intravenously. At that time, when there are fluid shifts, when the patient has edema, when the patient has been resuscitated, it's undependable to put pain medication sub-Q or IM. So it has to be intravenous. After about 2 or 3 weeks, grafts need to be done to the areas that did not regenerate. These 2 or 3 weeks are weeks of very intensive and extremely expensive care, but they are needed in very extensive burns where it's critical how much skin might resuscitate and what will not. That there is no substitute for this period of time. So in very extensive burns, this supportive care is given for about 3 weeks, at the end of which some areas we will be pleasantly surprised to see skin regenerating. They were in fact deep second degree. Some areas, unfortunately, will have only granulation tissue, and then we will do the necessary skin grafting. And the skin grafting may take, in fact, much longer to be achieved, to be completed, but it begins around the 3rd week. And then following the first day or two, when the patient has paralytic ileus and needs nasogastric suction, we also have to give intensive nutritional support, preferably in the GI tract, via the gut. High calorie, high nitrogen, very intensive nutritional support. The patient with burn has a tremendous catabolic state and needs an enormous amount of nutritional support. And finally, because I had to say something before I said the rest, but not because it is not the most important thing, rehabilitation has to begin on day 1. This is a terribly important concept. Survival is not the only objective of burn care. It's not the end point. We also need a functioning patient. And I know this is hard to accept, particularly by medical students, that are still motivated by their sense of compassion. They haven't seen the realities of burn care, and they see, for instance, a patient whose hands are burned. And the last thing that patient wants to do is to move those hands because they are burned and they hurt. But if you allow that patient to go for 3 weeks with immobile hands, even if that patient survives and you later do grafts and things, that patient will have useless hands from there on until the rest of his life. And so rehabilitation has to begin on day one, even when it is painful. And you'll see that the burn therapists insist on that patient, that the patient open and close the hand many times every day. Keep those muscles working, keep those joints from becoming stiff. Rehabilitation is an extremely important part of burn care. Well, let's move to the last of the burn vignettes. It's going to touch upon an issue that in a way belongs to the experts, but in a way, if it's given to you in a pretty simple, stark choice, is actually fair game for a fourth-year medical student. I pointed out already in talking about the general management and the general support of a burn patient, that those 3 weeks during which we wait patiently for skin to regenerate if it is going to, for granulation tissue to be ready to accept a graft, during those 3 weeks, the patient needs very intensive and incredibly expensive care. Patients in a burn unit, we're talking about thousands and thousands of dollars every day. And we're not only talking about dollars and cents, we're talking about pain and suffering and risk. A patient who could get septic, a patient who has nutritional, tremendous nutritional needs. All of that could be obviated. All of that could be avoided if we had a situation where we could, from day one, excise and throw away all the burn areas and put a skin graft. Now, this is obviously something that we cannot do in the very extensive burns. There isn't enough skin left to enable us to have this cavalier attitude that we're going to throw away all the burn areas, even those that might have regenerated skin. But in a very circumscribed third-degree burn, very small surface, clearly third degree, even a fourth-year medical student would have no trouble realizing that the best management is what we call early excision and grafting, immediate excision. Let me read you a vignette that I think makes it a very clear choice. Vignette number 21, a 42-year-old woman drops her hot iron on her lap while doing the laundry. She comes in with the shape of the iron clearly delineated on her upper thigh. The area is white, dry, leathery, and anesthetic. These are all descriptors of a third-degree burn. It's a very small area. It wouldn't make any sense to have this patient in the hospital for 3 weeks getting silver sulfadiazine and care, waiting for that very small area to be ready to accept a skin graft. This lady is taken to the operating room the day she comes in. We excise and throw away the burn area and put a skin graft, and she goes home the same day with tremendous savings in cost, in pain, in complications. So keep in mind early excision and grafting. It's the thing to do for limited, small, third-degree burns. Now, if you were a burn expert, you would extend that concept to considerably bigger burns, but you are not assumed to be a burn expert when you're taking step 2. So I don't think you're going to be giving a 20% burn or a 15% burn or a 25% burn and made to decide, can we do early excision and grafting or not? It should be an easy one like the one that I read. We're going to conclude the review of trauma with a few vignettes that deal with bites and stings. Vignette number 22. A 6-year-old child tries to pet a domestic dog while the dog is eating and the child is bitten by the dog. So we obviously have an issue here with a wound that needs appropriate care. Like any other thing that penetrates the skin, we have to think about tetanus and what prophylaxis might be needed. But this, being a dog, raises the additional issue of rabies. So let's review a little bit what are the standard recommendations for rabies prophylaxis. In a domestic pet, presumably vaccinated, very low risk, if the bite is considered to be provoked, we don't feel the need to provide rabies prophylaxis. Now you might say, well, it didn't say anywhere in the vignette that the kid was teasing the dog, but dogs are very protective of their food. That's not the time to pet them. So if a child, messes with the dog at the time the dog is eating, the dog's response may very well be, this is my food, get out of here, and the dog bites the child. So we consider this a provoked attack. In other words, this doesn't mean the dog has become aggressive, has an unusual behavior. However, it doesn't mean we're going to forget completely about the incident. We'll provide the necessary wound care and tetanus prophylaxis if needed. But we take advantage of the fact that this is a domestic animal, and then that animal will be put under observation by a veterinarian. And at the slightest indication that the animal might be developing signs of rabies, in the very unusual case that might occur, then we can recognize this early enough to then take the necessary steps to protect the child. Now, vignette number 23. During a hunting trip, a young man is bitten by a coyote. The animal is captured and brought to the authorities alive. You say, hey, we can do the same thing. Let's observe the coyote for unusual behavior. But a wild animal cannot be observed for aggressive, unusual behavior. A wild animal that you put in captivity will have aggressive behavior. You cannot tell this animal is developing signs of rabies. But on the other hand, the fact that the animal was brought in is helpful, because now the animal can be killed. The brain can be examined. And if the brain of a coyote shows the signs of rabies, then the hunter that was bitten by the coyote will receive the necessary rabies prophylaxis. And if the animal is deemed to be healthy by the results of the autopsy, then you can spare the patient the pain and the expense and the risk of a rabies prophylaxis. Now, vignette number 24 doesn't give you that alternative. While exploring caves in the Texas Hill Country, a young man is bitten by bats, who of course promptly fly away. Bats are known to be a reservoir of rabies. And of course we now don't have an animal that we can examine. Unfortunately, this man is going to need rabies prophylaxis, and that means both immunoglobulin plus the vaccine. All right, let's move from rabies to snake bites. Vignette number 25. During a hunting trip, a hunter is bitten in the leg by a snake. His companion, who's an expert outdoorsman, reports that the snake had elliptical eyes, pits behind the nostrils, big fangs, and rattlers on the tail. The patient arrives at the hospital 1 hour after the bite took place. Physical exam shows 2 fang marks about 2 cm apart, and there is no local pain, swelling, or discoloration. Well, your initial reaction, if you're familiar with the description of snakes, is to recognize this is a venomous snake. The description here is a rattlesnake. And the patient was bitten. This is not only the history, you have the bite marks and the leg there to look at. And so your immediate reaction might be to say the patient has been bitten by a venomous snake and he needs treatment accordingly. No, don't jump to conclusions. This may come as a surprise if you were not brought up in snake-infested country or didn't have that kind of experience in your medical training. But up to a third of all the bites from venomous snakes, no envenomation takes place. In other words, the snake can bite you and inject venom, or bite you and not inject venom. Well, the most reliable sign that says there was envenomation is pain and swelling and discoloration at the site of a bite, and these are usually present within 30 minutes. So if we go back and we realize that this gentleman showed up in the hospital 1 hour after the bite took place, and that there is no local pain, swelling, or discoloration, clean the wound, tetanus prophylaxis as appropriate, but as far as a snake bite, all he needs is further observation. Because so far the indication is he was not envenomated. Contrast that, though, with the next one. Vignette number 26. During a hunting trip, a hunter is bitten in the leg by a snake. His companion, who is an expert outdoorsman, reports that the snake had elliptical eyes, pits behind the nostrils, big fangs, and rattlers in the tail. Yes, venomous snake. The patient arrives at the hospital 1 hour after the bite took place. Physical exam shows 2 fang marks about 2 cm apart, as well as local edema and ecchymotic discoloration. The area is very painful and tender to palpation. This man was envenomated. This man needs treatment. What's the treatment? Well, I have good news for you. The treatment of snake bites finally has become standardized, and now everybody agrees. If we had had this review 20 years or 30 years ago, there was a wide variety of opinions on how one should treat snake bites. Some physicians did the fasciotomy every single time. Some physicians excised the bite site. There was a great deal of enthusiasm for systemic steroids rather than antivenom. All of that has pretty much been resolved. The mainstay of therapy for snake envenomation is the specific antivenom. In fact, the specific antivenom is so much so the effective therapy that many of the other things we used to recommend are not recommended anymore. In this particular case, please do not pick the answers where you cut and excise the bite area. You don't need to elevate the extremity. You don't need to do a fasciotomy. You don't need to give steroids. All you need is the antivenom. But the antivenom has to be given in big dosages. At the very least, 5 vials, not 5 cc's, 5 vials. And in bigger cases of bigger envenomation, 10 or even 20 vials. But there are a number of other things that also are needed. Blood should be drawn for typing and cross-match, because the snake envenomation eventually interferes with typing and cross-matching. So if something were to be needed surgically down the path, and at that time blood had to be cross-matched, you couldn't do it. You also do coagulation studies and renal and liver function studies, because those are the areas that could eventually be affected in the bad cases. The surgical excision of a bite site, as I pointed out, the fasciotomy are very rarely needed. There is the occasional patient in very extremely severe cases where we have to do it, but not very commonly. Now, vignette number 27 will again come as a surprise to you if you are not familiar with snake bites. While playing in the backyard of our South Texas home, a 6-year-old girl is bitten by a rattlesnake. At the time of hospital admission, she has severe signs of envenomation. So I am assuming the area of the bite is painful and tender and discolored, and perhaps the little girl already has coagulation problems and renal and liver function problems. Well, you say, I already learned in the previous vignette that for the big Texas cowboy, we use from 5 to 10 to 20 vials. If this is a little 6-year-old girl, it ought to be from 1 to 2 to maybe 4. No, it's not. Antivenin is one of the very few medications where the dosage has nothing to do with the size of the patient, but with the size of the envenomation. And so if the little girl was badly envenomated, she may in fact need the 20 vials. And if she was less severely envenomated, 10 or whatever. Okay. All right, let's move into another topic. One that in fact kills far more people in the U.S. every year than snake bites do. Vignette number 28. During a picnic outing, a young girl inadvertently bumps into a beehive and is stung repeatedly by angry bees. She's seen 20 minutes later and found to be wheezing, hypotensive, and madly scratching an urticarial rash. When people die from bee stings, they die because they have an anaphylactic reaction. And epinephrine is the drug of choice. So this little girl needs 1/3 to 1/2 cc, a 1 to 1,000 solution of epinephrine. The stingers also have to be removed. Careful not to inject more venom as we do it. Let's now talk about a couple of spiders. Vignette number 29. While rummaging around her attic, a lady is bitten by a spider that she describes as black with a red hourglass mark in her belly. The patient has nausea and vomiting and severe generalized muscle cramps. Now the description of that spider is that of a black widow spider. That's what this bug is, black widow. And the black widow spider, the classical outcome of their envenomation is very severe muscle cramps. Severe enough, in fact, that in every residency training program in areas of the country where this spider is common, there are anecdotal cases of patients who had an exploratory laparotomy for an acute abdomen, and what they had is they had been bitten by a black widow spider. But the rigidity of the abdominal wall was so impressive, everybody was convinced that a catastrophic intra-abdominal event had taken place. So these can be very significant muscle contractions from the black widow spider. The antidote, the specific therapy, is IV calcium gluconate. Muscle relaxants can also help, but I think the answer you're looking for on this vignette would be IV calcium gluconate. Now the next one is another very common spider, but that does its evil deed in a little different way. A patient seeks help for a very painful ulceration that he discovered in his forearm on arising this morning. Yesterday he spent several hours cleaning up the attic, and he thinks he may have been bitten by a bug. The ulcer is 1 cm in diameter with a necrotic center and a surrounding halo of erythema. This one is a brown recluse spider bite. It hurts when it happens. The man knows something happened to him. He was bitten by a bug. Of course, the bug ran away. He never saw what it was. But at the time, that's all there is. Bitten by a bug, nothing happened. And within a number of hours, typically overnight, this ulcer develops, and that's dead skin, that's dead tissue with this halo of erythema. For that one, we do still local excision of the ulcer. We get rid of it. It's already dead tissue anyway. We get rid of the ulcer, get rid of the poison that's there, and eventually skin graft may even be needed. And then finally, this one wraps up our trauma review. It's a classic. And it is, although you will not think at the beginning, a bite also. A 22-year-old gang leader comes to the ER with a small 1 cm deep sharp cut over the knuckle of the right middle finger. He says he cut himself with a screwdriver while fixing his car. No, that's not what happened. This is a classic. The same way that people in the emergency room know that the burns and the buttocks of a little child mean child abuse, They also know that a sharp cut over the knuckle of the dominant hand of a bad guy is in fact a human bite. It doesn't mean somebody grabbed him and bit him. What happened is he hit somebody in the mouth with his closed fist. In doing so, the teeth of the victim cut his knuckle. But when he comes looking for care, he's not going to say, I beat so-and-so, he's bleeding in the alley. He doesn't want to take responsibility for that. So he invents a cover story. It was a screwdriver fixing the car. But we have to be able to see through that cover story and beyond. This is a human bite. Now, why is that important? I trust you remember that from a bacteriological viewpoint, a human bite is the worst bite that a person could have. Now, you could bite yourself if you want, because you live in symbiosis with your own mouth flora, but you don't live in symbiosis with the mouth flora of another person. And so these that appear so innocent in the emergency room, we know it is a human bite, and if it affects the joint, it could very well destroy it from the severe infection. So the orthopedic surgeons typically will take this to the operating room and do massive irrigation and debridement in the operating room for what we know bacteriologically is a very badly infected bite. Well, that concludes our review of trauma. We will have then other chapters to deal with orthopedics, with pre-op and post-op care, with general surgery, and with surgical specialties.